our speakers for today. We will start by introducing the first speaker. Rather, he is the second speaker, but we're introducing him first. So welcome, Professor Simeon Isezuo. Like I told him some days ago, I have been rehearsing how to pronounce this name correctly. Our professor is a distinguished medical practitioner and an academician. He has made significant contributions in the field of medicine. He has done work around research, and he has a number of academic achievements. He obtained his medical degree from the University of Ibadan. And he has a passion for cardiology, and he pursued that passion. He has obtained certificates in cardiology. He has a passion for cardiology and echocardiology from institutes in countries such as India and China. He has also received several awards and honors throughout his career, including fellowships from prestigious medical societies. Professor Isezuo has published 75 scientific publications in various international and national journals. He has also served as an examiner in the Faculty of Medicine, National Postgraduate Medical College of Nigeria Fellowship Examinations. He is a member of the editorial board of the Nigerian Journal of Cardiology and has been editor-in-chief of the Sahel Medical Journal since 2000. His passion for medicine and cardiology has made a significant impact in the life of his patients, and he continues to contribute positively to this field through his practice and through the extensive research work that he does. So please, a round of applause for Professor Simeon Isezuo. Please, a round of applause. I need to see the claps in the chat, except you don't want him to teach us today. I need to see the claps in the chat. Yes, well done. Well done, people. Okay, I see it on some people's profiles, so well done, thank you. And so as our second speaker is, in the spirit of International Women's Day that we just celebrated some days ago, we would like to introduce Dr. Ejiroghene Umuerri. She is a strong education professional with a medical degree from the University of Ibadan. And she has a master's in public health from the University of Wolverhampton in London. She's an associate professor from the Department of Medicine and the Delta State University, Abraka, and a former associate dean with a demonstrated history of working in higher education industry. She is a fellow of the West African College of Physicians and the National Postgraduate Medical College of Nigeria. She has over 10 years of experience as an honorary consultant physician and cardiologist in Delta State University Teaching Hospital in Ogara. She's actively involved in voluntary community service and development, and she's skilled in healthcare, clinical research. She uses a number of the softwares that most of us are familiar with, but she has also contributed extensively to the medical field, especially within the Delta State region and other parts of Nigeria. So with a round of applause, let us also welcome Dr. Ejiroghene Umuerri. So I want to see hands in the chat. Thank you, thank you, thank you. So yes, you are welcoming our speakers well. So we're sure that they're going to be happy to teach us today. And so we will start off very quickly, like we say, ladies first. We will start off quickly with Dr. Ejiroghene Umuerri's presentation, Improving Medication Adherence. She's going to be giving us an overview. Okay, so the next voice you will hear is Dr. Ejiroghene Umuerri's voice. Hello, Ma, can you hear me?
Yeah. Good afternoon, everybody.
Good afternoon,
Adora. Your voice has been very soothing, and I've just been mesmerized in all your talking. I think I want to start by, first of all, thanking MDoc. This is a great initiative, and all the partners, Northwestern University, University of Abuja, and of course the University of Abuja Teaching Hospital, and all the other people who are partnering with MDoc to bring this program to pass. Like you said, this is the 6th in the series, in the 8-part series. And without wasting much of our time, we would go straight to the topic of the day. As has been said, my name is Ejiroghene Umuerri, and I work in Delta State, Nigeria. I'm going to be looking at improving medication adherence, and we'll follow this outline. We'll define what medication adherence is. We'll briefly talk about hypertension and medication adherence. We'll look at the different types. We'll look at the factors that influence medication adherence. Are there consequences of non-adherence? And then we'll look at a few strategies to improve medication adherence, and then how we can also assess medication adherence. So at the end of this brief talk, it's expected that we should be able to define medication adherence, know very clearly the difference between adherence and compliance. We should be able to describe factors responsible for medication non-adherence, and also understand the role of counseling in improving medication adherence. Next slide. Now, what is medication adherence? Medication adherence is the extent to which a patient's behavior corresponds with the prescribed medication or dosing regimen. That is to say, at the point of contact between the patient and the healthcare provider, something happens. Now, how far the patient can carry out the instructions given vis-a-vis the medications prescribed is what we refer to as medication adherence. So really, it refers to whether the patient takes the medication as prescribed and whether the patient continues to take the prescribed medication. So the patient can be taking the medication, okay, and still not adhering. We'll find out why soon. And it's important to know that adherence is essential to target outcomes. So if you want your patients to do well, if you want blood pressure to be properly controlled, then medication adherence is at the center of it. And unfortunately, medication adherence as we speak still remains low. Now, what is adherence and what is compliance? Next slide, please. Now, adherence implies that the patient has received advice from the healthcare provider on his condition. So the condition the index condition we're focusing on now is hypertension. So it behoves on the healthcare provider to inform the patient, because we find sometimes you see patients who are hypertensive, who are taking antihypertensives, but yet they tell you, I don't have hypertension. So there's something missing, there's a gap somewhere. Not only knowing the condition, you should also inform the patients on the importance and the benefits of the prescribed medication, as well as telling them some of the possible side effects that they should watch out for. Whereas, on the other hand, drug compliance, it's not a horizontal relationship like adherence. It's a vertical relationship in which the healthcare provider takes the authoritarian attitude. So he issues out an order, makes a prescription, and the patient is left with no choice but to comply with the prescription. So he doesn't know why he's taking the medications, he doesn't know the benefits of the medications, he doesn't know the possible side effects of the medications. So next slide. Now, if you look at adherence versus compliance, adherence, simply put, is the healthcare provider forming a collaboration with the patient, a horizontal collaboration, face-to-face collaboration. Whereas compliance is an order. The patient is expected to obey the healthcare provider's orders. And that is why you see clearly that compliance is struck out. We should not be talking compliance in today's world. We should be talking adherence. Next slide. Now, the index condition we're looking at today is hypertension. And we all know what hypertension is. We know that it's a chronic disease. We know that it's progressive. And we know that really and truly that the blood pressure, there's a critical blood pressure that if you do nothing, then the patient is at risk of having low quality life, having increased morbidity, having increased mortality. Whereas if you do something, and that something could either be pharmacological, which is drugs, or lifestyle. If the patient does not adhere to the medications, the antihypertensive medications that is being prescribed to take care of all the possible problems that can come from hypertension, then that patient is a double risk for that patient. In other words, we can say very clearly that non-adherence to antihypertensive medication is a well-established cardiovascular risk factor. The patient is open to all the problems that comes with hypertension. Now, there are different types of non-adherence. It could be primary. In this case, the healthcare provider makes the prescription, hands it over to the patient for one reason or the other. For one reason or the other, the patient decides not to fill the prescription. So the patient goes home without the prescription being filled. That will be called a primary non-adherence. For secondary non-adherence, the patient fills the prescription, starts taking the medication, but somewhere along the line, stops taking the medication, again, for whatever reason. But this time without the advice of the prescriber, the physician. That will be termed secondary non-adherence. Whereas the tertiary non-adherence is the situation where the patient prescribes the medication, the health care provider prescribes the medication, but the prescribed medications are not taken as prescribed. In other words, for example, you say, take this medication, let's say amlodipine, for example, take 5 milligrams of amlodipine, take it once every day. The patient goes home and decides to take 10 milligrams, or the patient decides to take the medication twice a day instead of the once daily that was prescribed. That will be termed tertiary non-adherence. Now, whether primary, secondary, or tertiary, medication non-adherence could either be intentional or non-intentional. Unfortunately, by far the most common type of non-adherence will be intentional. So the patient will intentionally not fill the prescription, the patient will intentionally stop the medication, or the patient will intentionally not take the prescribed medication dose. Now, several factors influence medication adherence. And the World Health Organization has actually broken these factors down for us. This into 5. So you could have social or economic factors. It could be factors related to the medication itself. It could be factors related to the disease. It could be patient-related factors or factors related to the healthcare system. I will take a bit to describe this. Now, for social factors, please go back to the previous slide. Socioeconomic factors, it could be that the patient has no support. So you have an elderly patient who lives alone or lives or has a nurse that looks in, or a caregiver who may not be well motivated, to give the patient the medications as prescribed. Or you have a prescription that is made and the patient does not have the money to buy the drugs. So that's very easy for primary non-adherence. Whereas for therapy related, in this instance, you're looking at the drug itself. What is the dosing frequency of the drug? How many drugs does the patient have to take? Some patients take as much as 10 drugs every day, out of which some will be twice a day and others once a day. So there's a risk, especially for elderly people, for this patient to be confused and to have some form of medication non-adherence. Disease related. As far as hypertension is concerned, this is very important because we know that hypertension is largely an asymptomatic disease. So it doesn't cause any symptom. The patient is feeling fine, the patient is okay, and he doesn't understand why he has to take any pills and would intentionally drop the medication or take it for some time. Maybe the blood pressure was high, the blood pressure comes down, and then the patient decides not to take the medications again. Of course, patient-related factor. Some patients who are physically impaired, so they may be visually impaired, they may have some hearing impairment, or they may even have cognitive impairment. So for example, we have a patient who is diabetic, who is hypertensive and also has dementia. That patient is going to rely on somebody else completely to be able to take his medications. And it behoves on whoever is, administering the medications to do as it pleases. So that is something to also consider. And of course, the health system related factor. And I'm happy this is one of the benefits of this session, because the health system is being strengthened, to ensure to play their role in medication adherence. So patients, the communication between patients and the healthcare provider should be strengthened if medication non-adherence is to be a thing of the past. Next slide, please. Now, what are the consequences of non-adherence? These are myriad. It could be to the patient directly, in which case the patient will suffer disease progression. The quality of life of the patient will be reduced. Of course, we know with increased morbidity and hospitalization, the quality of life is never the same. And then the patients are at risk of premature deaths or even, just deaths if they're elderly. And the potential harm of overdosage is also there. So it's not only that the patient is undertaking the medications, the patient can also overtake the medications. And of course, there are consequences beyond the patient. There are consequences to the healthcare system. There are consequences to the nation. So there's wastage of time, there's wastage of resources, if patients don't adhere to their medications. How do we go around medication adherence? Patient counseling. This is key, particularly in hypertensive patients and in chronic diseases generally. Now, in counseling patients, there are key things that must be addressed. You want to let the patient know the type of drug that they are taking, why they are taking the drug, when they should take it, for how long they should take it. The question of when always comes up. And as far as hypertension is concerned and antihypertensives, or generally, particularly for medications that are once daily dosing medications, is to tie it to the patient's convenience. So the time that is most convenient, the time that the patient is not likely to forget, the time that the patient's routine. So if the patient takes, there's some patients who will always take breakfast, or there's some patients who will always take dinner. So you want to tie the timing of that medication to that daily routine of the patient. And of course, you want to counsel them on common side effects that they should watch out for, the necessary ones. If you look at inserts of most medications, the side effects are gamut, but you want to highlight the common ones that they should watch out for. And also you want to advise this patient to have medication adherence aids, like calendars, like diaries. The mobile phone is very handy in setting alarms and all of that. Now, what are the strategies to improve medication adherence? Again, the strategies could be physician-related, patient-related, or healthcare system-related. But I'll just go and do an overview on some approaches that we can take to improve medication adherence. So the first thing is that the healthcare worker must understand his role, must be educated enough to know the reason why the medication is being prescribed, the importance of the medication, and the benefits of the medication. Now, beyond knowing the medical knowledge, the patient should also, the healthcare provider also has the responsibility to improve his own communication skills. So you must be friendly and approachable. You must show some empathy. It's not, people don't come to healthcare facilities if they don't have problems. So you must be able to empathize and you must be an active listener. So you listen to the patients and then you want to provide as much solution as you can. And in doing so, in the course of the counseling, you want to address certain myths and misconceptions. You hear people say, I don't take my medication, antihypertensive medications, because once I start to take them, then hypertension will never go away. Or once I start to take them, it means that I will be taking them for life. And if I'm doing that, there'll be so many side effects, all sorts of things. So if the healthcare provider is well educated, he'll be able to dismiss with facts the common myths and misconceptions on medications as far as hypertension management is concerned. And of course, you want to pay attention to labeling and packaging. So there's no room for removing medications from the blisters, from the packets, and making them anonymous. You're just creating room for confusion for the patients to either mistake the medications or not adhere to them, or just be careless with them. Of course, whatever advice or counseling you're doing, as much as possible, you also want to involve the social support system of the patient, particularly if they're elderly or if they have one form of physical challenge or the other. We have said that you should tailor the regimen of the patients, the regimen to the patient's convenience as much as possible. You also want to involve the patient. Next slide. You want to involve the patient in the discussion. So it's not just, next slide, please. It's not just the healthcare provider dishing out information to the patient. The patient should be involved in the discussion actively. So you want to actively listen to the concerns of the patient, and you want to guide them using very clear and simple language. And at the end of the discussion, you must pause to do a check. You want to check if the patient understands what you have been saying. And lastly, as much as possible, the prescriber should use very simple dosing regimen, and where possible, use fixed combination. This will help to reduce the pill burden and, of course, improve medication adherence. Now, how do we assess medication adherence? There are two methods generally. Next slide. There are two methods to assess medication adherence. It could be direct or it could be indirect. So for the direct, you want to observe the patient take the pills, directly, as is commonly done in some TB patients. And then you also want to measure the blood level of the drug or the breakdown product of the drug, the metabolites of the drug. Now, as far as antihypertensive medication is concerned, this may not be a very effective method. Yes, it can be used, but there's a better method for antihypertensive medications, and that would be the indirect method. Now, for the indirect method, next slide, please. For the indirect method, it could be subjective or objective. Now, the subjective one would commonly use an interview or questionnaire. So you have a questionnaire, for example. The common one will be the Morinsky Medication Adherence Scale 8 questionnaire that has 8 questions, and you ask the patient, and then you are able to score the questionnaire and know whether the patient is adhering or not adhering to the medications. Or you want to objectively do a pill count, so you know how much pills were dispensed at the last encounter, last visit, and how much pills the patient has presently. Of course, this is done without some errors or some intentional. Some patients may, particularly if they know that you're going to count their pills, may intentionally waste some of the medications. And of course, as part of the indirect method, the objective indirect method is also looking at the secondary data-based analysis. So the patient has a diary, for example, or a calendar. You want to look at the diary and you want to see, what the patient has entered. And in more advanced countries, they also can monitor these patients electronically. Now, what is our take home from this short talk? Medication adherence involves effective, underline the word, effective communication and collaboration between the healthcare provider and the patient. Medication non-adherence is common among patients with chronic diseases, hypertension inclusive, and there are multiple factors responsible for medication adherence. In other words, you cannot pin medication adherence usually to one factor. There are several reasons why a patient would not take the medications. And for the same reasons, there are several ways that can be used to reduce patients' non-adherence to medication. Counseling by the healthcare provider is critical in reducing medication and non-adherence, and in improving patient outcomes and survival. So each time you counsel a patient, each time you help a patient to improve their adherence, you're not just helping them, to take the medication, but what you're really doing is you're improving the patient's quality of life and improving the patient's survival. And of course, we know that the indirect assessment of adherence using the subjective method and the objective method is effective. Thank you very much. These are my references.
Thank you so much. Thank you so much, Dr. Umuerri. Thank you for trying to keep to time. Truly appreciate it. So we'll move very quickly to Professor Isezuo, and he's going to be speaking to us on improving medication adherence, looking at it from the Nigeria perspective. And once he's done with that, we'll take a few questions, as we have some of them already coming up in the chat, and then we would go into like a case-based discussion. So please open your ears, because we would like your contributions during the discussion. For some of us, it's interesting to know, even from Dr. Umuerri's presentation, that there is primary non-adherence, secondary non-adherence, tertiary non-adherence. So these are key things that we should be taking notes of and including them in our knowledge bank. So we will be handing over very quickly to Professor Isezuo. Sir, can you hear us?
I can hear you, Adora. Thank you.
Wonderful. Okay.
Thank you.
I'm trying to see, is your video on so that we can see you as well? Yes, we can see you now.
Thank you.
Welcome, sir. Please go ahead.
Okay. Let me join Dr. Ejiroghene in thanking MDoc and partners for inviting us to participate in this series. I'm going to bring the topic home. What is our experience among Nigerian patients? And adherence to antihypertensive, very, very much oversimplify, take your medicine. Looks so simple. But if it is so simple, we will not have many patients with stroke on the world. We will not have many patients with chronic kidney disease, heart failure, myocardial infarction. We will not have too many, oh, I saw him yesterday, he was in the market yesterday, sudden death. Just take your medicine. Looks so simple. Next slide. So we hope at the end of this lecture, we will probably see how a little bit difficult this simple advice is. What are the barriers? What makes it difficult? And how can we practically and simply improve adherence? And we should also be able to utilize and be aware of feasible measures that we can use to monitor adherence. Next slide, please. We'll follow this outline. Next slide. Next slide, yeah. As I've said, we'll be zeroing down on Nigeria experience, and in doing this, we have to bear in mind that this is a nation where 7 out of 10 are living below poverty line, where cost of health care is out of pocket, and 1 out of 3 Nigerians are illiterate. Next slide. We have this, what we call rule of 1/3, that is still applicable to many societies, including Nigeria. Of all the patients who has hypertension in the community, only 1/3 are aware that they have hypertension. So the remaining 2/3 are the ones that will develop serious problems. Of the 1/3 who are aware that they have hypertension, only 1/3 are on treatment. And of the 1/3 who are on treatment, only 1/3 of them have their blood pressure controlled. In other words, only 1/3 of them adhere to their medications. Only 1/3 of them take their medicine as enumerated and described by the previous speaker. Next slide. And in fact, our experience in the whole nation shows that in terms of awareness, only 3 out of 20 patients who have hypertension are aware that they have hypertension. Next slide. However, many of these currently would have been started on treatment at one time or the other. So you can see the larger problem is less of awareness, although that's a problem, but more of adherence. Next slide. And majority of our patients, as has been recently well described and published by Dr. Oji, are on more than one drugs. When we reviewed this in 2005, 8 out of 10 of our patients are on more than one medicine. Next slide. However, many don't have their blood pressure controlled, as we mentioned earlier. So if you go to the tertiary hospitals, the secondary hospitals, general hospitals, virtually 3 out of 10 patients who have hypertension, including those who are even coming to the clinic, have their blood pressure controlled. Next slide. And the consequence of lack of blood pressure control arising from lack of adherence would include stroke, heart failure, chronic kidney disease, and these days, what was previously not known but now becoming very common, heart attack. These are the consequences of poor adherence to antihypertensive medicine. Next slide. This is very applicable to our patients. Again, repeating what I have said before, virtually 1 out of every 3 patients who have hypertension develop complications in our environment. Next slide. We use this simple method to assess the level of knowledge of hypertension among our patients. And we were interested in whether they knew the risk factors, they know whether hypertension has symptoms or not, how would hypertension be diagnosed, is it curable, and the blood pressure be controlled. Next slide. What are the complications? And what are the blood pressure control measures? And we have a total score of 100. Next slide. Morisky also designed a simpler methods of assessing knowledge of hypertension among patients who has hypertension using just only 3 questions. When you feel better, do you sometimes stop taking your medicine? Sometimes if you feel worse, when you take your medicine, do you stop it? Do you know the long-term benefit of taking your medicine as instructed by doctor? Next slide. When we applied our proposed instrument to many of our patients, what did we find? If we consider 60% to be pass mark in terms of knowledge about hypertension, we discover that only 20% of our patients are knowledgeable about hypertension. Next slide. They are not knowledgeable in the sense that almost all of them believe that hypertension is because of stress. And this is what we hear every day. When we say somebody has hypertension, the next comment is, I'm not surprised. You know, if he's in this era, they say he's always talking, he's not sleeping, he's always attending political meeting. So I'm not surprised. they think that stress is the major cause of hypertension. Where I practice, a good number of patients also think that cola nut is a cause of hypertension, others coffee. And we have a number that still think that witchcraft is a cause of hypertension. Luckily, however, a good number also are aware that salt consumption in excess and overweight are also risk factors for hypertension. Next slide, please. Equally disturbing is what most of our patients think could be the solution to hypertension. And Nigeria being one of the most religious countries in the world, virtually everybody thought that prayers alone can cure hypertension. And if we administer a quiz even to participants in this program, I'm very sure that only maybe less than 1% will say that prayer cannot cure hypertension, because that would be like denying your religion. And many others think that things like sobo, garlic, onion, carrot, even traditional sacrifice can cure hypertension. The time we did this work, almost 2 decades ago, supplements were not too common. If you ask anybody these days, he will also tell you that supplement is one of the means that you can cure hypertension. Next slide. So we can see that many of our patients don't even have average knowledge about hypertension, and many misconstrue stress as a cause of hypertension. Many also believe that hypertension has symptoms, the dominant symptoms being things like headache and insomnia. Next slide. Next slide, please. And a lot of our patients believe that hypertension is curable. Because they thought that hypertension had symptoms, you have a great number, almost 65%. When they don't have symptoms, they don't take their medicine. And in fact, some will tell you they know when their blood pressure is high because there's a way they feel, and that is the only time they take care of their medicine. It is important that we are aware of these misconceptions and belief among our patients, so that in counseling, we can handle them appropriately. Next slide. Without motivation, it is difficult to adhere, because hypertension is a lifelong disease and medication has to be taken for life on daily basis as at now. So you require motivation. So it is also necessary to determine what is the degree of motivation among our patients, and Morisky scale can simply be used also to achieve this, as enumerated in this slide. The less motivated your patient is, the more intensive your counseling in terms of adherence. Next slide. Next slide, please. So 70% of our patients live below poverty line, and that is an important factor in non-adherence. And 70% belong to low socioeconomic status, and virtually all has no access to insurance. However, poverty is a problem, but it may not be the only problem. Next slide. In these studies by our colleagues is part of the South, medications were provided free of charge. And I think the organizers of this program are doing the same thing in some of the centers that they are partnering with. And yet, from the experience here, shows that in spite of making medicine available free of charge, only less than 36% of patients, have a good blood pressure control, which means they were not adhering. So it's more than just poverty. So ignorance may be a major factor. and illiteracy and lack of knowledge about hypertension. Next slide. In spite of the much well-known poverty, it is important that we also understand and make our patients understand that the cost of treating complications of hypertension is by far, far, far higher than the cost of just controlling blood pressure. In addition to that, when most of the complications you cannot reverse. Only few patients, I can count the number of patients I have that had stroke that recover fully in my over, getting to 4 decades of practice, perhaps maybe in my 10 fingers, very few. This study shows that if a patient has kidney disease, for example, without complication of the kidney disease, the cost of treatment increases by a factor of 9. By the time the patient requires dialysis, the cost of treatment increases by a factor of 30. Next slide. What are the reasons that our patients have preferred for not adhering? The commonest that we have found is absence of symptoms. And we are not surprised because most patients believe that hypertension is symptomatic. Lack of fund, again, which is related to poverty. Side effect of medicines. So this, we should always try to let the patient be aware of that hypertension, most of our medicines have minor side effects, but these side effects are very little when you compare it to the complications of hypertension. Busy schedule and forgetfulness is also common among our patients. This is mainly among those whose poverty will not be a problem. So I advise such patients, buy your medicine, have the money, put some in your car and put some in your office in addition to the one at home, so that when you forget to take it at home, you take it in the office. Or if you remember it while you are driving, you pack and take your medicine. Non-available medicine in the place of domicile is another complaint. So we should try to prescribe as much as possible medicine that are available. Some patients also said one of the reasons is that they have exhausted their medicine. So the pharmacy and the doctor should work together to ensure that the prescription is given, is counted, the number of the medicine is counted, and ensure that it will serve up to the required clinic appointment. What I do these days is to give medicine in excess of 1 to 2 weeks for my patients. Normal blood pressure during the last clinic visit is another reason why many patients don't take their medicine. This again is common. They say, oh, my blood pressure is normal, I will stop taking my medicine. The fear is that if he or she keep taking the medicine, the blood pressure may now go below normal. And many of them must have been told that low blood pressure is more dangerous than high blood pressure. So you see them being very cautious. So they need to be educated that when the blood pressure is normal, it's like titration. That is the amount of drugs or medicine that is required to control the blood pressure. Next slide. So in counseling our patients, we should be able to tell them what is hypertension and what is not hypertension. What is not hypertension is very important, and it's probably easier to communicate that hypertension is not because of stress. You should also let the patients know that hypertension is a common problem. It is almost an entitlement for anybody that lives long. You can be likely to gray hair. It's only that gray hair is inconsequential, while high blood pressure is consequential. The risk factors should be explained, and that patients should also be told that the only way they can know that you have hypertension is by having the blood pressure measured, not from the symptoms. The consequences of hypertension should be told to the patient, but without causing unnecessary alarm, so that fear will not kill the patients even before the disease. Patients should be told that hypertension cannot be cured, but the medicines has to be taken for life, and these medicines are very safe, having been used for almost over 100 years. Family reinforcement has been found very useful. So counseling can be done in the presence of the husband and the wife and the children, particularly in the elderly, so that there could be, encouragement of one another. Next slide. Whenever I say hypertension is genetic, I use these simple explanations that the gene is the building block of the body, and what is causing hypertension is in one of these blocks. So it is not just a matter of stress alone. Other factors will come in, but this is the main fundamental factor. Next slide. The measures that could be taken to improve adherence will include health talk. We should try to organize regular health talk in line with what we have been discussing today in our clinics. Clinic compliance is also very important. I tend to favor fixed duration of clinic appointment. This may have implications in terms of frequent visit and so on. But in other words, what I'm trying to say here, if I want to give a patient 1 month appointment, I maintain 1 month appointment so that the patient develop the habit that he's supposed to come to the clinic or she's supposed to come to the clinic every month. Of course, for those who are well knowledgeable from my assessment, I can modify this and give the appointment as officially required depending on the level of blood pressure. Single fixed dose drugs in a single tablets taken daily as much as possible should be encouraged. The medicine we are prescribing should, as much as possible, be affordable. And this is where socioeconomic status assessment is important. We are not talking about class treatment where you give a good drug to one person and probably drug not so good to another person. But when we have insurance that cover wider proportion of the community, then we can practice the idea of making sure that the best medicine is given to every patient. But for now, where medicine has to be purchased out of pocket, we may have to be a little bit balancing the two. Next slide. I always use this as to counsel my patient. I will say there's a disease called hunger, and this hunger, you have to take your food every day to make sure that you handle it. And if you can do this, then you should be able to also take your tablets every day to prevent the numerous complications of hypertension. Next slide. What are the feasible ways? As mentioned by the previous speaker, the ideal method of electronic monitoring of adherence is not practicable. Perhaps the one best way of measuring adherence indirectly is blood pressure control. So once your patient's blood pressure is not controlled, you have to assume that there is non-adherence or poor adherence and counsel accordingly. We have also tried to advocate direct observed therapy. This is useful in elderly patients so that a close relations administer the drug to the patient and see the patient swallow the medicine on a daily basis. Of course, this will also, the adherence to this will be required of the person giving the patient the medication. Some of the questionnaires that we have talked about during the course of the two presentations, particularly the Morisky and the one we have proposed, could be used to measure adherence among our patients. Field count, I'm not too sure how useful it is, but it's a possible method provided the patient is honest enough to bring the remaining medications as actually it is. Next slide. Okay, this is the more risky questionnaire for monitoring adherence. You have to ask 4 questions. For a patient who is adhering, the answer to all the questions should be no. If the response to any one of these questions is yes, then the patient is non-adherent. So forgetting to take medication is a feature of non-adherence. And not taking the medications, is also a feature of adherence. So in summary, there are several factors that could be responsible for non-adherence, and this is what has been enumerated in the previous lecture: patient-related factor, illness factor, barriers, then our healthcare providers. Then the sociocultural factor is very important. For example, in our patients who are fasting, luckily, most of our drugs these days is taken once daily. So it's not going to be useful to prescribe a medication that will require 3 dosages in a patient who is fasting. So cultural sensitivity is also useful, and family reinforcement in terms of raising funds to take care of patients who are poor among the family could also be useful. Next slide. Yeah, I've already mentioned this. Again, so summarizing now, adherence, simply said, take your medicine. Look very, very simple. Very, very simple. But it can be difficult. Difficult because there is freedom. Anything that involves choice, patient can choose to adhere, choose not to adhere. Anything that involves choice in life or freedom can be difficult. Difficult in 2 ways. Difficult to implement. Difficult to implement in this situation because hypertension is a chronic disease requiring lifelong treatment, which is not easy. It is also difficult in the sense that this simple message of take your medicine is not easy to deliver. Communication. So this brings in the 3rd competence aspect of we practitioners. You may have the knowledge, all the knowledge about hypertension. You have the skill, all the skills required in treatment of patients. But if you don't have the attitude of counseling your patients, having a listening skill, then most of your patients will not adhere. And I think it's our hope that these presentations and this effort by MDoc will have improved our attitude and also knowledge in management of hypertension. Next slide. Next slide. Thank you very much.